Welcome everyone to this month's People Care Health Services Community Connections. My name is Michelle Ray Meredith and I'll be your moderator today. Today's guest is Carlene Martin. She's with Shield Healthcare, which is a disposable medical supply company that has been delivering supplies to the home since 1957. Let me tell you a little bit about Carlene. Carlene has worked within the medical industry for 35 years in various positions. 30 of those 35 years have been with Shield Healthcare. Outside of her commitment to Shield as a senior territory sales representative, Carlene has dedicated much of her time serving on a variety of volunteer boards and committees within the industry, including the Colorado Gerontological Society, Spina Bifida Association of Colorado, Medicaid DME Advisory Committee, and CAMES, which is Colorado Association for Medical Equipment Services. Carlene, share a little bit about CAMES with us.
Okay, very good. Well, CAMES, as you said, is the Colorado Association of Medical Equipment Services. And what we do is we meet monthly, and we are advocating for our consumers, and we're advocating for ourselves as well. So as an example, we have run several bills through the legislature downtown. We're doing a lot of lobbying, and currently there is some legislation out there that originated from our federal Congress that we are now working on to run a bill through, because we're trying to hold tight onto our Medicaid reimbursement as they want to do some reimbursement cuts with us right now. So those are the types of things that we're doing. We're just lobbying to make sure that we can all take care of people at home.
Excellent, excellent. Well, I'm ready to hear your presentation today.
Okay, all right, very good. Well, thank you. I appreciate the opportunity. Some of these slides you're going to see are talking about Shield, because I think it's important to know a little bit about the company. But a lot of the slides, even though they're about Shield, they're going to be about education. We're all about education and support for our referral sources, our clinicians, and our consumers. So that's what we're going to go through. So our first slide talks about the different products that we have. So we're doing incontinence, and that's actually what my talk is going to be on today. When we get into it, it's going to be living well with incontinence. We're doing ostomy supplies. We do catheter supplies. We do enteral nutrition and oral supplements, because it is a covered benefit under Medicaid if we can prove medical necessity. And we do wound care. We do the simple wound care items, and we do advanced wound care as well. Just a little bit, again, as I was going to tell you, background about Shield. We've got 400 employees across 10 states. 30% of those employees have been with Shield more than 10 years. And I recently went to our awards dinner, and my name tag did have 31 years. And I was a little shocked and said, well, I started at the age of 2. So, but we've also have over 23 hours a year in training, as well as we're product experts. So as an example, even though I'm not a nurse, Shield has sent me through wound certification training so that I'm able to walk the walk and talk the talk and know the product, so I can assist, whomever it might be. Move on. A little bit, Michelle already talked about a little bit about our local community involvement, but the president of our company says that the community's been good to us. We need to give back to the community. So these are just some pictures that they have of some local things that we do. Michelle mentioned the Spina Bifida, so we always do their walk and roll. The Colorado Gerontological Society always has their senior day downtown, so we volunteer for those types of things. And then as you, everybody's always being looked at in star ratings and surveys and questionnaires, and there's really nothing other than your accreditation for a disposable supply company or a DME company as a whole. So every year we hire Press Ganey to do a survey on us, and we surveyed over 3,000 consumers, and I think the numbers up there are fantastic, but the one I like the best is that Shield scored better than 99% of the comparable companies also surveyed by Press Ganey. And that's because we're focusing on, again, the education and support. It's not about the product, it's about the education and support. So the next slide just talks about a little bit, again, we lost some of that. The expertise, the experience, and the excellence. So that's okay. We can just move on. That's good. There it goes. So, our expertise in product, our experience, the years, And this was the slide, just shows all of the associations that we do belong to. We already talked about those a little bit. On the Medicaid DME Advisory Committee, what I do is we sit on a sometimes monthly basis or quarterly basis, each one of us around the room, oxygen people, wheelchair people, disposable people, and we work through scenarios again to make sure that we can all stay whole and take care of the patient at home. You move on. Okay. This is just showing our distribution center, and you can go ahead and move on. Anything that's ordered from Shield is usually to the consumer's door within 1 to 2 business days. And this is actually our warehouse. Little surprising for a disposable medical supply company, but this just guarantees that the product is to the consumer within that 1 to 2 business days, and this is where that 99% satisfied with shipment time comes in. One of our educational programs that we do have as well is our enteral nutrition support program. We do have registered dietitians on staff. Their main goal is to do feeding pump setups from a hospital, but they're also available for nutrition in services and speaking back and forth with the clinicians at the hospitals or even at some different physician offices, those types of things. This one is just talking about our Shield Healthcare communities. And when you go on our website and you would click communities, you will see down there at the bottom, it says nutrition, it says ostomy life, urological. And when you get into each one of those, you will see a host of different educational opportunities, whether it be a video, whether it be a webinar, whether it be just an article that's written. The one I would like to just talk about here real quickly is that we have you can't see it on there, but we do have a caregiver tab there. And we always honor caregivers because that is who is taking care of the individual in the home most of the time. So every year we've had a contest, what makes caregiving rewarding. This year we switched it up a little bit and it's called, what advice would you give a caregiver? And out of the 3 winners, the top 3 winners, we had 2 in Colorado. So I was just so happy to be able to go deliver $500 American Express gift certificates. We had a winner in Greeley and then one in Fort Collins. So we're really honoring caregivers, and there's just so much information there regarding caregiving when you get to that tab as well. Quickly move on, Laura Cox. This is more for somebody, an individual, a consumer in the home that's had an ostomy, and she actually has an ostomy herself. And here we show her. She was on the celebrity profile on Comedy Central, Tasha's .0. He was interviewing her. You can see he was, obviously comedy. He's sitting on a toilet, but an ostomy has fecal matter coming out of their stoma. So that's what he's talking to her about. But what her goal is and what she's doing for us is just to make sure that because you have something chronic happen to you does not mean life needs to end. So she's just like a cheerleader, rah-rah, inspirational person out there. And then we also have Aaron Baker, who is our spinal cord injury specialist. Aaron is doing the same thing for us. You can see 17 years ago, he broke his neck while riding a motorcycle, and he had a 1 in a million chance of ever feeding himself or walking. And through determination and struggle, he actually, you can see him riding a bike. He rode a bike across country. They had it modified for him. And he joined me in a dinner last year that we sponsored for the Chanda plan. And he can walk. He walked his wife down the aisle. So again, it's just to the consumer at home, to the patient that's having these, to deal with these, that life is not over. We can continue moving on. On our online wound, we have wound out there as well. I just kind of highlighted this one because when we're talking about wound healing, there's always lifestyle factors that are involved. How long is somebody sitting in a chair? Are they getting out of bed? Are we repositioning them? Are we doing those types of things? So I just wanted to point those out. And then here's some great education pieces. And I just want to let everybody know that if there's anything, you should have some copies of these that I had forwarded on. But if you want actual copies for yourself, I'm happy to give you whatever you need. So the first one, we are dealing with a lot of elderly patients all the time that tend to not get good nourishment. and sometimes it develops not necessarily the not good nourishment, but they develop some types of wounds, some pressure ulcers. And so because our dietitians, they put together this great flyer on top 5 nutrients for wound healing. The one you see on the screen is not the one that you should have. The one that you should have should actually have the daily recommendations, which are great to hand to actually anybody, you know, within the population that we're servicing, you know, the calories that they need. And then what I do like about it too is it does have some recipes on the back as well. Sometimes we just need to get extra calories into those individuals. Pressure ulcer staging, not much for you probably at this stage, but we will go into a little bit, because sometimes a pressure ulcer might look just like something like incontinence-associated dermatitis, which we might see with those incontinent patients as they move forward. So knowing the difference between them, because treating them is a little bit different. So for those out there of you that might be out there that are clinicians, this is a wound management guide. So it's just a little pocket guide talking about staging, treatment summary, kind of like a little algorithm that you would have if you talk about what stage it is or what the drainage is like, and then we make a suggestion for wound care product. But we also go into simple things like skin tears. You know, we see a lot of things, you know, simple skin tears in our population. So it goes into even those things. Now we're going to kind of start on our incontinence. And this is a page that we pulled from our website as well. And I kind of highlighted a couple of things: keeping your bladder healthy. We, you know, always hear about UTIs. Ways to reduce urine odor. We know sometimes when we walk into someone's home, or sometimes when we even walk into a facility, you know, you can definitely smell that odor. And then avoiding urinary tract infections. That's a nice article on here. And as I go on, I'll talk a little bit more about that and where you can get some more information, since I'm really talking more just about living well with incontinence in this presentation. Also, go ahead and move it, I'm sorry, how the diet affects bladder control. I'll talk a little bit about that as we going on, but again, it's out there for you on our website. It's all out there. And then some resources that you have. I don't know that if everybody knows that Medicaid actually covers incontinence products in the state of Colorado for anyone over the age of 4, as long as there's a qualifying diagnosis. I know many times we go into someone's home and we see that the product is sitting there on the floor in the restroom, so we automatically assume that they're being taken care of, and they might be buying them at the store. So knowing if you're servicing somebody with Medicaid, that it is a covered benefit under the.
We have a question, Carlene. The question is, what criteria or diagnosis does Medicaid require for an incontinence product?
There's nothing in black and white. We just have to state that there is a primary diagnosis with incontinence as a secondary, because incontinence is a condition, not a diagnosis. But even if you had, I mean, typically we see Alzheimer's, we see dementia, we see CVA. In our kiddos, we see cerebral palsy or spina bifida. But you can also have a situation where somebody may have COPD and they may have severe arthritis and they just can't get to the bathroom in time. And we'll talk about a little bit about that too as we come across a couple of other ones, the fall risk factor, because of, you know, some of the diagnoses that are happening. So, and here it is. So there is a relationship between incontinence and accidents and fall accidents. Incontinence episodes may lead to a little bit of leakage that might get on the floor. So we have to be careful with that. Urgent incontinence, which we'll talk about too, means that you have to go to the bathroom now. And so sometimes people hurry to get to the restroom, and so they fall. Or frequent trips to the restroom at night. You know, if the path isn't clear or it's dark, they may trip and fall. So this is actually one of the tools we have, and you should have this too. It's a fall prevention tip. It just goes through the different areas and what you might recommend to somebody. You know, clear your rugs out, you know, clear the pathway out, those types of things. So these are, again, things that I can provide as education tools for you should you want them to hand out. We talked a little bit about incontinence-associated dermatitis. These are just 3 flyers that we have. And we'll just move on with this one because we'll talk about it a little bit more. And then we'll actually get into the incontinence piece. But this is a webinar schedule. We also host webinars monthly. And we've been doing it for about 2.5 years. So if you were to go to that website, at the bottom of that flyer, you would see a library of webinars. And like you have here, you can go back and review any of them. Some of them, if it is a nurse watching them, can get a CE on them if they have it. What I did point out here, I wanted to point out here on this one, this is our 2018 first half. And in April, we're having tips for coping with caregiver depression and stress. And then in June, aging in place, strategies for staying safe at home. Because the goal for anybody is to just remain at home. That's what they want to remain. Then, of course, Shield wants me to put in there that we're social. So please like us on Facebook, Twitter, those types of things. So now we'll move on to living well with incontinence. And I'm sure that everybody knows the definition of incontinence, but it's a partial or complete loss of bladder or bowel. And sometimes I think people always just think about it as bladder, not necessarily always bowel. It's not a disease, but it's a condition. And it's often it's a symptom of something else, a medical issue or certain medications. Certain medications that we take can cause incontinence. There's actually 25 million people in the United States with incontinence. 40% of women over 55 have incontinence. 50% of women over 65 have incontinence. And every year, 4 million doctor visits regarding a UTI. So it's more of I don't want to say it's a problem, but I think it's out there more than people know. And it's also coming out. It's something that used to always be in the closet. Nobody wanted to talk about it. But now you see advertisements on TV where some of our TV stars are showing they're wearing a Depends pull-up product because they want to come out with it a little bit more. It's nothing that, it's not a stigma any longer. So the big picture when we think about it is the fact that for safety, there's a fall risk, skin damage, and infection. We talked about UTIs. Oh, keep going. Social, odor, noise, travel or bathroom access, stigma, and independence. I know when my mom, she was in a wheelchair, and it was really challenging to always find a bathroom that you would think it shouldn't be these days, but it was challenging to find a bathroom that we could get into. So, and the psychological issues, just the shame, guilt, frustration that goes along with that, fear and isolation. We find so many people that don't want to go out of their home based on that. But then some ideas that we can focus around as caregivers in talking with somebody is just let them know that they're not alone, and let's talk to somebody else about this, even if it's just your physician. Let's go talk to the physician about it. Avoid antagonizing language or making them think that it's their fault, because it's really not their fault. And bringing in various products. We do provide sample incontinent bags, and this is one of the reasons that we do provide these, is so that you can take these in the home and let people touch and feel and say, oh, they're really not that bad. Maybe this is something that I could use. So we offer these to anybody that would like these. So they're sample incontinent bags, but that's one of the reasons that we did, because I think that most people think of incontinence products as something similar to a baby diaper, but there are some great products out there. And then again, not using that word that I just used, we should be using words like briefs or disposable underwear or liners. So that can make them feel more comfortable. And then always light humor. Like we saw back on the slides with Laura Cox when Tosh was sitting on a toilet talking to Laura about her problems. So, just having that light humor. So, and then let's go ahead and talk about the different types of incontinence. We have urge or overactive bladder, and that is the sudden intense need to go. My mom had that. She would be like, 1 minute she'd be fine, she'd be, I have to go. And we could not get her to the bathroom in time. And sometimes it's a condition related to maybe a brain injury, perhaps a stroke, MS, Parkinson's, Alzheimer's, dementia. Then we have stress incontinence, where the bladder is pressured or stressed, and that comes from, if you cough, if you sneeze, if you laugh. And then we have overflow, and that is when your bladder doesn't empty completely, and then eventually your muscles no longer are contained in a normal manner, and so then it allows overflow. So it's nothing you can stop, it just overflows. And then of course we have functional, where you just can't get to the bathroom in time again, where it's just a result of a physical or mental impairment again. Then
we have another question, Carlene. If incontinence is so common, why is there still a stigma about it, apart from the embarrassment?
I think people just don't want to know. I mean, they don't want anybody to know that they're incontinent. I mean, again, it's the odor. I visit a lot of assisted living facilities, and they ask me to come in and set up a table, Carlene. And I did that just this last week, and not a single person came to my table. But yet, if I were to go behind a wall and sit so nobody else could see them coming to me, then many people would come up to me. Mm-hmm. My mom was not afraid to tell anybody that she was incontinent. But it's just a, nobody wants to be incontinent. I mean, I don't really know how else to answer that, other than some people just don't want anybody to know. Again, odor. And there's also that, it's funny, in the skilled nursing facilities, I've been in this industry so long, but it used to be, they would say, well, you can hear Mrs. Smith coming because the swoosh, 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 swoosh of the product that they were wearing. Now they no longer make products so that they make them so that they have quiet film, so they don't make the noise. So nobody just wants anybody to know that that's happening. There's a Canadian gentleman, I can't remember his first name, but his last name is Phage. But he actually has come out, he has fecal incontinence as a result of a sphincter problem. And so more and more people are coming out, and they're trying to get more and more people to say it's not that big of an issue. You just need to come out. So, okay. Yeah. I don't know if I answered that. I'm sorry. And then fecal, we have the neuromuscular, which is, like spinal cord injury, MS, stroke, anatomical, which is, could be a congenital defect, stool consistency, which is diarrhea, and functional, which is just the inability to control. So like I said, sometimes we only think about incontinence as urinary, but so many people do have fecal incontinence as well. And then of course, there's a low volume versus a high volume. And we have to look at the different types of treatment. We have to look at the different products needed. We have to look at the life impact and the cost. I always like to bring in some personal stories. I told a little bit about my mom, but my brother was diagnosed with colon cancer. And for a variety of reasons, I was purchasing his pull-ups. And at that time, this was 9 years ago, they were $1 a piece. He went through 4 a day. So that meant that I always times everything times 30, because I'm in that world of Medicare, Medicaid, everything is times 30. So that was $120 a month. So if you can think about somebody that's on a limited income, they don't have that money. So, just trying to find the appropriate product for them. The frequency, again, and the predictability. You see the commercials on TV with some of the products now, the medications that they have. One was to say, gotta go, gotta go, gotta go, gotta go. So, sometimes you just can't always find a restroom. So then the risk factors: age, chronic cough, obesity, with diabetes, pregnancy and childbirth, hysterectomy, prostate surgery, MS, we have paralysis, and then we have medications as well. And then the next is just the front view of our urinary tract infection. So we can see that the kidneys are attached to the bladder through your ureters. And then you have that sphincter muscle down there at the bottom, and then the urine flows out through the urethra. And sometimes it's that sphincter muscle that people tend to have problems with, that in controlling their bladder. And then on the anatomy, and then we do have some different products too that men have a longer urethra, so there's less risk for stress incontinence for them. There's a higher risk for retention, and they have more options for external types of devices, which we'll go through some of the different products here. Those are some slides on there. So they have the options for some external devices as well. So in men and women, the different risks. Women are coming from a lot of meds or surgeries that they've been on. Obviously, childbearing, stress incontinence. Men, because of enlarged prostate or cancer. Post-prostate procedure issues. And then they've also discovered that there's a correlation between incontinence and erectile dysfunction in men. That should be dysfunction, shouldn't it? Maybe not. So let's go ahead and move on. And we have, the financial costs, disposable versus reusable products. And, we also think of that too of our environment. Some people are starting to go back to using the reusable and washing, but the products that they're making now are breaking down a lot better in our environment.
Would that be going back to the embarrassment issue? If you, I'm not sure, would it be better to use something that's disposable all the time or something that's you're using reusable?
Right. Exactly, because it's in your trash can. I mean,
Right.
If you're disposing it, it's in your trash can. One of the things that is very big right now is that when we deliver product in non-discrete boxes because people don't want a box showing up to their door that says depends. So now boxes are discrete.
Just makes you wonder if you're trying to take the stigma away, maybe we should just get it out there.
Right. I know.
Double-edged sword there.
Yeah, I know. I think it probably just depends on the individual and how they feel about it.
Sure.
And I think that probably women are more, we'll talk about it a little bit more than maybe men will. That's just my own thought under that. And then so the cost, we have briefs, and again, sometimes when we always think of incontinence, we always think of a pulp product. When I say pulp product, it's a brief, it's a pull-up. But we can also look to catheters. We can look at intermittent catheterization. They don't have it on here, but Foley catheters, I guess that would be the continuous. And then laundry and furnishings and carpet. When you do have the problem, if somebody has fecal incontinence function and they can't absolutely hold it, what are the costs involved with that? And then the environmental cost of it as well. So urinary incontinence, some of the precipitating factors, infection, UTIs, it's one of the larger ones. Intake, what we're intaking, caffeine, artificial sweeteners. Also, there's some other products, chocolate, spicy foods, sugar, honey, that they say it may not necessarily cause it, but it can contribute to it as well.
So can we train our bladders then if we stay away from certain things?
You can train, and we'll get into that in a minute. There is something you can train your bladder, yes. And I want, before I go on, I want to talk, since the camera is on me, we have this book called Living Well with Incontinence, where I have pulled a lot of the information that I'm talking. So if you would ever like copies of these, please contact me. My contact information should have been on that first slide, and then it's also on the back of each one of our literature. But yeah, it talks about, here's the one on diet, milk. You wouldn't think of milk, tomatoes, citrus, highly spicy foods I talked about. So, and then also, if you don't get proper hydration, it can be a problem. So I actually have a slide coming to that, so we'll talk about that. But then we, again, talking about the retention leading to overflow, just again, the prostate enlargement, post-surgery. And then it's funny, the school teacher's bladder, and I put a note on here, or the Shield Healthcare sales rep bladder. That's the one where you never go to the bathroom all day long because you're going, and you can't stop to go to the bathroom. So sometimes people can relate to that if it's in their car all day long. So that's what that school teacher's bladder is. And then this slide would just be something, it just talks about the different types of incontinence surgery. These would be what you would probably speak most with your physician about. But we thought we would put them up there to know that there are some different surgeries out there that you can certainly have done, but that would be more up to your physician. Talk about environmental things that we can do in the home besides the fall risk sheet that we had, removing the carpets, those types of things. We can always get a bedside commode for somebody, room closer to the toilet, a bell or a baby monitor so that somebody can alert somebody that they need to go to the bathroom, eliminating barriers. We can always use urinals. And those are sometimes used, we see that used a lot in the hospital. Somebody just had a surgery and they're using a urinal, portable or an installed, or a bidet or a washlet toilet seat, or even the raised toilet seats that can, those are just environmental modifications that we can help somebody with. And then also dressing. This is something my mom, bless her heart, she's no longer with us, but she wouldn't mind me talking about this. She fell, broke her hip, and got a little dementia from it, became incontinent. So this is something that we had to start doing. We had to start changing her wardrobe, because since she was then in a wheelchair, we had to find clothing that were really simple, pants that had elastic. We had to buy a larger size to accommodate, so that if she was wearing the pull-up, nobody would see that she was wearing that pull-up. Easily washable, Velcro and elastic, zippers or snaps. So it's just, those are some things to think about when you're talking to somebody about it. Let's just make things a little bit easier, instead of you're trying to go and trying to unzip and unbutton and all of these things. So, and then on the toileting, we put this in there because there's sometimes some issues for men that perhaps have a little dementia or something, making sure that they can aim so that they get it into the toilet, the urine stream into the toilet. So they show here some pictures of, you can buy a colored toilet seat, and always make sure that there's a grab bar next to it so that they can stabilize themselves. And then they actually put here, you can put electrical tape to outline the rim of the bowl. And then always a rubber floor mat, because you don't want to have a carpet or some type of a little rug there that they can easily slip on. So if you have anything there. Some toileting tips we can talk about. Scheduled voiding, prompted voiding, and I'll talk about that in a little bit. Watch for signs of needing to go. Limit your fluids in the evening. Resting during the day with the feet up can reduce nocturia. Nocturia is needing to go at night all the time. Invest in a wet, dry vacuum cleaner, incontinence pads on the chair, and then obviously finding a good practitioner, somebody that can really help you through some of the problems, instead of just saying, here, let me write you a script for this. You can really talk about your problems with them. And again, I talked about this a little bit already, managing it. Avoid alcohol, coffee, artificial sweeteners. I did this with a presentation, not necessarily this one, but to an Independence senior center the other day. And they said, well, I can't have anything anymore. Can't have alcohol, can't have chocolate, can't have coffee. And then avoiding dehydration. And there is a formula that you can use to determine the amount of fluid that somebody should take. And as an example, somebody that's 55 years old, about 150 pounds, should actually have 10 8-ounce glasses of water a day. And you need to be hydrated. This is, again, bless my mom's heart, but this is something she would think about. If she had a doctor's appointment, she wouldn't drink anything all day. And then, because she didn't want to have to go to the bathroom. But then in 2 days, she'd have a urinary tract infection, which caused more incontinence, because you need to keep your system, you need to flush out all of those toxins. So keeping hydrated is particularly important.
Can you share with us the math on how you got that?
And again, if anybody, it'll be in this book if anybody wants this book, but it's 0.067. Let me read it out of here. I just can't read my handwriting. Sorry, everyone. So it's 0.067 mLs times the body weight for an average 16 to 55, 0.057 times body weight for 56 to 75, So you can see as we get a little bit older, it decreases a little bit. And 0.048 times body weight for an individual that's over 76 years old. And sometimes under hydration, it can, if you're on diuretics, some of the medications, Alzheimer's and depression, you just don't drink enough fluids. So, but I know that that's a thing that everybody always thinks of. If I don't drink enough, I won't have to go to the bathroom. But again, it'll just have a reverse, because you're going to get a UTI that's going to, and my mom would always, then she'd call me on a Saturday night at 5 o'clock and she'd say, I think I need to go to the urgent care because I have a UTI and I didn't want to bother you. Bless her heart. So we're going to kind of go into some of the products, and we talked some of the external products that men can use. So we have men can always use an external, a condom catheter, sometimes we call them external catheters, that would actually hook up to tubing to a leg bag. And some men prefer to use that. They feel that they can hide it a little bit better than, again, using a pad. I feel maybe they can, because leg bags tend to have an odor barrier in there to protect the odor on them. Then we can also move on, and some people would rather just do intermittent catheterization. And you can see here that it's showing you that there's a variety of different intermittent catheterizations or intermittent catheters. We originally started with the red rubber latex catheter, and since then we've kind of moved on to some different ones. It just depends on what you like more so. You like the catheter a little bit stiffer, or if you like it a little bit softer. So, but people, what they do is they insert that catheter, it voids into the toilet, and then they pull it out and they go on their day, and they might do this 4 to 6 times a day. And that's how they're cathing. Of course, the next one we have is the indwelling, or as some of us know as the Foley catheter. And the risks of this are definitely infection, and then definitely odor with this one. And sometimes we see people that go in and have a suprapubic catheter placed, as opposed to going through the urethra. They have a stoma place where it's going directly. They place a catheter directly into the bladder. So sometimes you hear the suprapubic term. So that's another one. And this one, of course, would hook up to extension tubing, as well as either a leg bag, or if it's at nighttime, a nighttime or night drain bag. Then we go into the general absorptive type products. So those would be your pads or your briefs, the tape up or the pull up, your chucks, disposable or washable. So sometimes you see, even like in Bed Bath & Beyond these days, I've actually seen where you can buy the washable waterproof sheeting that you can place on the bed. So when we're talking about low volume incontinence, this is when we would probably wear something that we can wear in our own underwear, and we could probably place in, there's a variety of different types of liners, which is why I always like to show people that they can let everybody see that not one size fits all. People can choose the different types of liners they would like. So this would be for our low volume type of incontinence. They have a stickiness to the back, so it would fit right in their underwear. And as we were talking earlier about men's anatomy is a little bit different. So there are also products now for male, so that this definitely would not work in the underwear like this. So this would actually be placed more up like this into their underwear. So these are the types of products that we would have available for them. Then when we move on to the higher volume, that's when we can move on to more of our pull-ups or our wraparound briefs with tape, or we call it disposable underwear as well. Now, in terms of Medicaid, if anybody's interested to know the quantity guidelines on these, somebody is allowed up to 8 changes a day. They're allowed up to 150 underpads or chucks. They're allowed 2 boxes of gloves a month. And also, if we've gotten into the incontinence-associated dermatitis, which we'll talk about here, they're allowed creams and washes as well. So
is that adequate amount?
Yes. Most people won't need to use that many product. Most people are around 3 or 4 a day. And just because those are the guidelines does not mean that that's how many everybody gets. We usually say, how many times a day do you change your pad? And then we again calculate that times the 30, and that's how we determine their needs for that product. So we will ship the product. We will actually do all that. We will contact the physician, get the documentation, do all that calculation, and then ship it to their home. So that's what our role is in this whole process. We talked a little bit about the underpads. Again, they're allowed 150. In the state of Colorado, though, they do not cover the mattress covers. They only just cover the disposable product. And then the cleansers, this is so important because on the pages way in the beginning, we showed those 3 slides that were going this way, and it was showing a picture of incontinence-associated dermatitis. Because stool and urine is such a harsh chemical that it actually is damaging to, well, we know that it's damaging to the skin, but it alters the skin's normal healthy bacteria, making it more susceptible to friction and tension. And then wet skin has lower temperature and less blood flow than drier skin. So that's when that friction, so you've got somebody that's constantly moving around or sliding around in the bed or something, that's when you start to get that breakdown in there. So the fact that we can, and the cleansers that are out there that are available, they have the pH balance that'll match what the skin needs. I mean, you can certainly use another, soap or something, but they really focus on, and that's where your wipes come in as well. They have that pH balance that tries to bring the skin back.
Carlene, would you need a prescription from your doctor to obtain these?
If we are billing Medicaid, yes, you do. But again, that's something that we will obtain for you. Now, in Colorado, the wipes are not a benefit of the Medicaid program. So therefore, we go with the no rinse wash. And then as we move on to the next page, we have skin protectants. And those are usually a barrier cream. Some have zinc in them. Some are petrolatum, the crusting technique. And then there's a product out there called Marathon. And some of these products, I would just recommend that when you're using them, some are really very, very thick. And when my mom had to be placed in the skilled nursing for a while, they were using a product that was so thick that when they would pull her pull-up down, the product would just like roll right off with it. So make sure you find a product that's really going to soak in and is going to be a barrier, because you want to protect the skin from the urine and the feces, not just a lotion. It's got to have a barrier component to it.
So is this something that can be bought like over the counter?
You can buy these products over the counter, yes. If it's somebody, again, that we've determined has incontinence-associated dermatitis under Medicaid, we can, of course, get it covered under the Medicaid program as well. Okay. These are some of the risk factors for fecal incontinence. I'll go through this very quickly, but frail and elderly, because at some point in time, as you get older, they have the inability to kind of hold their stool. Loose stools or diarrhea, obstetric injury. Again, we talk about our spinal cord injury, our cognitive impairment, anal surgery, radiation. Comes a lot, radiation and chemo from our folks that have had cancer. And that's kind of where my brother had come into play, with the radiation, the chemo, just couldn't control it any longer. Managing fecal incontinence. We talk about trying to go regular times, normalize the stool texture, avoid foods that cause loose stools, encourage foods that promote formed stools, the BRAT diet, low residue diet, obviously your anti-diarrheal medications, always the ointments to protect the perianal skin area. Sometimes many folks, like our spinal cord injury patients, have a bowel management program so that they're using a specific regimen, so that they will insert it like a suppository at a certain time every day, so that they can kind of get regulated with that as well. And then a colostomy would be the last resort, because that's exactly what a colostomy is they are taking the colon to the outside of the body, and then that's where your fecal matter comes out during that. Constipation and diarrhea are the most reversible causes, and sometimes people, they might have a leak or a blowout from constipation because it moves around it, and then post-constipation can last for days. Diarrhea it's harder for the sphincter to contain the liquid than solid, as we already know. It's increased frequency, increased volume, And then again, the unpredictability of diarrhea. Treating constipation, drink plenty of fluids, exercise, fiber, stool softeners, laxatives, suppositories, enemas. That's where we see sometimes people doing the bowel management programs. Treating diarrhea, the brat diet, bananas, rice, applesauce, toast. A low residue diet, that's for folks that might have Crohn's disease or colitis. And again, avoid caffeine, dairy, your triggers, and keep a food output or a diary. Medications we know can cause diarrhea, pectin, marshmallows, and peanut butter. And it's funny, I know you probably don't deal much with ostomies, but sometimes when I do ostomy support groups, an ostomy because it has no sphincter, that stoma has no sphincter, so it's constantly producing stool coming out. But sometimes people have found that if they eat a couple of marshmallows, the marshmallows will stop the peristalsis, so it might stop it for a little bit. So that's why they're suggesting the marshmallows here to kind of, cause it's like it kind of binds it a little bit. You know, marshmallows are kind of gummy, you know, the pectin in them. So, and then again, medical treatments, bulking agents, anti-motility, suppositories or enemas. One thing that I did not go over, I quickly, is that you can, on urinary incontinence, you can definitely, well, not everybody can, but some people will try and train their bladder. So with the recommendation of a physician, and I always have to say that because I can't tell somebody to just do this, but you can do bladder retraining. And so what you're basically doing is, as soon as you get up in the morning, you void your bladder. During normal waking hours, you empty your bladder at specific times that you've worked out with your physician. And during those times, even if you don't have to go, you still go in and you try to go. If you do need to go and it's a time that is not your time for voiding that you've got on your schedule, there's some things that they say to do some deep breathing exercises, do some Kegel exercises, and I'm sure that everybody probably knows what Kegel exercises are. Relaxing, and then just sitting until the urge passes, because you're trying to just retrain your bladder so that you go at specific times as opposed to, you know, whenever it wants to go, whenever you feel the need to go. And then if the urge does not go away, then you can certainly, you know, go and use, obviously, the restroom. And then as you accomplish your time interviews, increase them by 15 to 30 minutes so that you can, you know, so that you can go less during the day. So there is a bladder retraining. And in the back of this book, it also gives you the little bladder journal so that it can assist you through training through that process. So, and I think that I am probably done, and I really went past my time, but
No,
I appreciate it.
You are fine, Carlene. We'd like to open it up right now to any questions that you may have for Carlene. I'm just kind of curious, if you retrain the bladder and you get it to a segment of time, is that healthy? I mean, how often should we be relieving our bladders?
Well, I think that is up to each individual. But I think that you have people that go to the restroom all of the time. You know, when they get up in the morning, then 10 minutes later, then 10 minutes later, because they just might feel that need. And what they're trying to do is, you might feel that need, but do you really need to go? So that's what they're trying to retrain it, so that you're not constantly, because for some people, it's just not, you know, you might have a working schedule that doesn't allow you to get up every 10, 15 minutes to go to the restroom. So again, that's something that you have to work out with your physician, but it is something that if you go in, it's one of the things that they begin talking to you about is, let's talk about some bladder retraining.
All right, we have some other questions here. Nicholas asks, are there any vitamins or minerals that can help with this system training?
That I do not have an answer for. I wish I had a registered dietitian sitting next to me. I can certainly get back to you with that, though. I can, and I can email Michelle. So that I'm sorry, I don't have an answer to that one.
Right. And Jeanette has a question also. She says, How do we get a copy of the booklet she's been using?
Yeah, this has been like my Bible during this whole thing. You can either shoot me an email and I will send one to you. That's probably the best thing is I'll just send one to you from our warehouse. Yeah.
Would you like to provide your email to
Yes.
our audience?
It's kmartin@shield, and I always SHIELD healthcare.com. Many people always reverse it, EI, so I always have to pronounce or spell it. So it's kmartin@shieldhealthcare.com.
And you can also shoot me an email directly. You have mine, and we'll get that information to you. We have a few more minutes for any other additional questions that you may have. So go ahead and we'll open the lines or hold up your hand. So I'm just kind of curious, going back to the beginning of your presentation, what is the difference between a DME and what Shield does?
So that's a very good question. We fall under the DME umbrella with Medicare and Medicaid, but when DME actually stands for durable medical equipment. And as you can see, every product I talked about is going to be thrown away. So we used to do all of the product groups. We did wheelchairs, walkers, oxygen, but at one point in time, our president of our company said, we have to become a master of something, and we're going to become master of this. And that's why we're able to provide so much education. When you try and be a jack of all trades of everything, it's just hard to really focus on one area. So that's a little bit of difference between that.
Okay. Well, Carlene, I want to thank you for presenting to us today. I would like to also throw out Carlene Martin's email once more to you so you can get in contact with her. Go ahead and provide that again, Carlene.
kmartin@shieldhealthcare.com. Also, if you'd like any of the other literature, I'm happy to get that to you too. I know some people have somebody in mind they'd like to hand out to the top 5 nutrients, that we should be getting, those types of things. And I just want to thank you for your time today. I appreciate the opportunity and look forward to working with you.
Excellent. And if you'd like to provide some of those with us, we'll get them out if someone reaches out to us.
Okay.
Again, everyone, thank you for joining Community Connections. We will be here next month at the same time, which is the second Wednesday of each month at 1 p.m. Looking forward to having you tune in again next month. Thank you very much. Thank you again, Carly.
Thank you.